stomach.
Hi everyone, we're just going to wait for a couple more people to join, so we'll just wait a couple of minutes before we start.
We can just exit the presentation and then we can see everything. Yeah, that's my stomach.
Hi everyone, we're just going to wait for a couple more people to join, so we'll just wait a couple of minutes before we start.
We can just exit the presentation and then we can see everything. Let me get meant to be done. How many people are on the call, Charlie?
There's about 20 people now, and there's still some people sort of trickling in.
Good.
So I don't know if you want to sort of introduce yourself and get started, and then people can keep trickling in. It's up to you.
Yeah, no, it's up to you. It's your call.
Should we get going?
Yeah, sure.
Yeah, great.
Okay, thank you. So, welcome everyone on a beautiful Friday morning. Well, at least it is here in East London. I'm in Corrina's house in East London. My name is Jayne Kavanagh. I'm an associate professor medical education at UCL Medical School, and a specialty doctor in abortion care services at Homerton in East London. I'm also the co-chair of Doctors for Choice UK and helped to set up a project called Education for Choice, where medical students go into state schools and give evidence-based workshops on abortion and contraception. And I'll let Corrina introduce herself because those activities all overlap with what Corrina does. So you introduce yourself, Corrina, and I'll go on to talk about the other two things I do.
Hi everyone, I'm Corrina. I'm a community sexual and reproductive health trainee working at the Homerton in East London. And as Jayne says, all of those things sort of overlap. So I help Jayne with the teaching at UCL. I also work in the abortion service at the Homerton Hospital. I am the lead for education within Doctors for Choice, and I help run Education for Choice in several different medical schools. So I'll hand back to Jayne to let her explain the extra bits.
Thank you. And the other pictures on the slide are of Abortion Talk, which is a charity that I helped set up a few years ago, whose aim is to destigmatise abortion care. And it runs, I'll talk a bit more about that at the end, actually. And also I've been part of the RCOG's Making Abortion Safe project, working in 5 different countries in Africa to help to destigmatise and support clinicians to provide safe abortion care. So as you can see, both Corrina and I are absolutely passionate about destigmatising abortion and educating, especially medical students, but all healthcare students and professionals around abortion care. And so what we're going to do today is we're going to give you a session based on what we think are the most important things for medical students to learn about abortion care if they only have 2 hours or an hour and a half to 2 hours. And we're going to leave time for questions, and you can either type the questions in the chat as we go along, and then we'll answer them. So Charlie will be monitoring the chat, which we can't see, unfortunately. And then she'll interject if she thinks it'll be appropriate to ask the question and answer it during the presentation, or she'll save it until the end of each section, and then we'll take questions then. So please just type your questions in as we go along, though. So we're going to start off by looking at UK abortion law, which I will talk about, and then we'll move on and Corrina will talk about the different types of abortion. Then I will talk about UK abortion provision in general, and then we'll finish off with Corrina talking about how we as clinicians can help to counteract abortion stigma and provide respectful care when we see people who want abortions. Okay, so we're going to start off with a Mentimeter quiz. So if you can log into menti.com on your phone, please, and use the code 68875832, or use the QR code on the screen. I'll just give you a minute to do that. And we've got a handful of questions here for you to answer, and Corrina will be monitoring the answers on her phone and letting us know who thinks what, and then I'll give you the answers. And yeah, just use your gut instinct for the answers.
It is working, just to let you know.
Yeah, I can see people have already started answering.
Fantastic. Yeah. So if you can answer this question, then if you're in, and we'll give you a minute. So women and pregnant people have a legal right to abortion in mainland UK. True or false? And Corrina's going to speak the answer when she thinks she's ready.
We'll just give you guys another 30 seconds to a minute to answer, and then we'll move through it. Okay, so far we've got 16 people have answered, 15 have said true, and we have one person who has said false. And that one person is correct.
Well done, the one person who said false. So you would think that that people have a legal right to abortion in mainland UK, but actually they don't. So abortion is still a criminal offence in the UK, and it was criminalised in the 19th century in 1861. And both people who have abortions and people who provide abortions can still go to prison for life, a life sentence, if they contravene this act. Okay, but which surprises a lot of people, actually. But this is the case, and people are still being imprisoned. 2 people have been imprisoned already this year under this act for having an illegal abortion. So the next question is about the Abortion Act, because clearly abortion is not illegal for everyone. So is this true or false? The effect of the 1967 Abortion Act was to allow certain legal defences to doctors who perform abortions. True or false?
We'll just give it another 30 seconds if anyone else wants to answer. If anyone has joined later and needs the Mentimeter code, by the way, let us know in the chat and we can always repeat it for you. Okay, so we've got 15 people have answered this one, 13 have said true, and 2 have said false.
Thank you, Corrina. And actually, well done. There's 13 people. It's true. So even though abortion is still a criminal offence, the 67 Abortion Act permitted abortion under certain conditions. This was never extended to Northern Ireland, where abortion was largely illegal until recently. So that's the reason why we can access legal abortion in the UK, because of the 1967 Act giving certain defences to doctors. And so in Northern Ireland, abortion was completely decriminalised in October 2019, where people have the legal right to abortion up to 12 weeks, and then conditions similar to the 67 Abortion Act from 12 weeks were introduced by government regulations. So that's the situation in Northern Ireland, which is ironic that Northern Ireland, where abortion was illegal for so many years, is now more liberal than mainland UK. So people have a right to abortion up to 12 weeks in Northern Ireland. So let's think a bit more about the Abortion Act then. So does it allow a pregnancy to be terminated if a doctor agrees that the grounds specified in the Act are met? True or false?
All right, so we've got slightly more mixed picture here. So 12 have said true and 4 have said false.
Okay, apologies, this is a bit of a trick question. It is false because 2 doctors are needed. So that's the only trick question. I apologise for that. So 2 doctors have to certify in good faith that the grounds are met. And when the 1967 Act was introduced, they imposed a 28-week limit. So abortion was legal if 2 doctors certified that the grounds have been met. It excludes nurses, so nurses are not allowed to perform abortions. And it's specified that abortions must be performed within an NHS hospital or an approved place. Okay, so you can't just set up an abortion clinic outside of the NHS. You have to apply to the Secretary of State for Health for approval. Okay, so that's a broad legal background. So is this true or false? Women's Home is an approved place, allowing individuals to have medical abortions at home via telemedicine. We're getting a really mixed picture here.
Yeah, this one's split people a lot more. So we've got 10 people have said this is true and 5 people have said this is false.
Okay. So it's actually true. So last year, Parliament voted to make regulations that were initially put in place during COVID to make abortion more accessible and allow people not to have to come to hospital to have an abortion. They made those regulations permanent last year, and this allows people to take both medical abortion pills at home, thus allowing no-test telemedical care, which Corrina will talk a little bit more about in the next section, sometimes called pills in the post. And the law specifies that this can happen up to 10 weeks in England and Wales and up to 12 weeks in Scotland. And this gives you some indication of how, if you allow people other than clinicians to regulate abortion, they'll come up with these arbitrary time limits that are not based in good practice, because it's different in England, Wales and Scotland. Okay, so the situation now is that the majority of initial consultations in abortion services will be done usually on the telephone or by video call. People should be offered a choice of an in-person visit if they want, but the majority of people just want a quick phone call or video call to start the process. And evidence shows that this is safe, it's effective, and it's made abortions more accessible to people. So this is now ongoing. Okay, question 5. In 1990, the Abortion Act was amended so that lawful abortion on grounds of risk to health was reduced from 28 to 22 weeks. True or false? So the Abortion Act introduced a 28-week limit, but it changed in 1990. We've got another split picture here.
Another very split picture. So we've got 7 people have said true, and 8 and 8. 8 people have said true, 8 people have said false.
Okay, well, thank you for voting. It's actually false. It's 24 weeks. So the legal limit for the majority of people is now 24 weeks. And I'll talk about the exceptions for that in about a minute after you've answered this question. So the 1990 amendments removed entirely the time limit on abortions for a fetus with a serious disability. True or false?
This is a slightly less split picture. So 10 have said true and 5 have said false.
Okay. So well done, those who said true. So there are now circumstances in which there is no time limit, and that is for serious fetal anomaly, or to prevent grave permanent injury, or to save a woman's life, in which case then only one doctor's authorization is required if it's to save someone's life. And I will just say here about language, actually. So when we quote directly from the law or other sources, we will use the term woman. Otherwise, we will use gender inclusive or gender neutral language. Okay, so 7, the law sets out the criteria for deciding when a disability counts as serious enough for an abortion. True or false? Again, completely split.
Yeah, another split picture. So we've got, about 8 saying true and 6 saying false.
Okay. Actually, it's false. And this is the thing about the law. It doesn't set out any specific criteria about when abortion is lawful or not lawful, except for the 5 grounds of the Act, which I'll come to in the next slide. So decisions about the seriousness of the disability are left in the hands of individual doctors, those 2 doctors that need to authorise the abortion, and the pregnant person. Okay, so they are the ones that decide whether an abortion is justified because of the seriousness of the disability. And these are the 5 grounds of the Act. So ground A is to save the woman's life. There's no time limit. Ground B, to prevent grave permanent injury to the physical or mental health. Again, no limit. And then clause C, which is that abortion is less risk to the physical or mental health of the pregnant person than continuing the pregnancy. And it's that clause that 98% of abortions are done under in the UK. So the vast majority of abortions are done way under 24 weeks, actually, which we'll come to in the abortion provision section. And then the next most common clause is clause E, which is that the child is likely to be severely physically or mentally disabled. Again, there is no time limit. So if we look a bit more closely at the certification form, so this is what we have to sign. So it has to be 2 doctors that sign this form every time we provide an abortion for someone. So we cannot proceed without signing this form. And if we do, and if 2 doctors if we don't sign it, or if 2 doctors don't sign it, that makes the abortion illegal and us liable to a prison sentence of 14 years. Okay. So if you look at the top section, you can see here with the red box that when we fill out this form, we put our name, then we put our hospital or clinic address, and then we have to ring to say whether we've seen or not seen or examined the pregnant person. There's hardly ever do we have to examine the pregnant person if they're in the first trimester. We just don't need to. But we do have to ring to say that we have seen or not seen. So you don't have to see the patient to actually fill in this form. And the majority of abortion care in the UK is actually provided by nurses. So you'll get doctors working in centres where there's more complex care provided, like Homerton, where Corrina and I work. But throughout the UK, the majority of abortion care is done by nurses because it's mostly straightforward, which Corrina will talk about when we do the clinical aspects. And so doctors are just signing these forms, mostly without seeing patients. And how can they do that? Well, if you look at the evidence, so abortion carries less risk of maternal mortality and morbidity than ongoing pregnancy and childbirth under 24 weeks. So abortion is at least 14 times safer than continuing the pregnancy and going than having an abortion. So it's always physically safer to have an abortion than continue the pregnancy. And psychologically, of course, if a person wants an abortion, then she's less likely to suffer any mental health or a triggering of any mental health conditions or any new mental health conditions if the resolution of an unwanted pregnancy is what she wants to do, of course. So therefore, if a person wants an abortion and they're not being coerced into it, then their mental health is better protected by enabling them to make that choice. And so it's always lawful to sign Ground C in the UK, where we provide safe abortion in line with clinical best practice, as long as it's what the pregnant person wants. And of course, it's always important to identify when you see patients that they are not being coerced into an abortion. But it's also important legally, because if someone doesn't want an abortion and you are providing them, you may not justify clause C. Okay. So, a couple more questions left. True or false, doctors with a conscientious objection have the right to withdraw from their duty of care to a person requesting an abortion? I think everyone's getting this one right. Oh, not quite everyone. Oh, wrong, should I say?
Yeah.
Sorry, can't actually see clearly through this phone.
I was thinking.
Yeah.
So the majority of people have said true, and a couple of people have said false.
So actually, it's false. So even though you have we as doctors have the right, the legal and professional right to opt out of participating in abortion care, we don't lose our duty of care. So we still need to make sure that someone can access an abortion. And we have to give them information to enable them to access an abortion as well. So we have a professional responsibility to A, not block access to abortion, and B, facilitate access. And of course, unless one is needed to save life or prevent serious harm, when you lose your right to conscientious objection. Okay. And the BMA, both the BMA and GMC have additional guidance on this. So the BMA says that yes, of course you have a legal and professional right to opt out of care, but you mustn't use this right to disrupt patient care or impede access to care. And the GMC says that you absolutely, they've just updated good medical practice. So this is going to be replaced next year. It's quite similar though. You must, again, tell patients of their right to see another doctor and make sure they have enough information to exercise their right. And you must not cause patients distress. And in our UCL teaching, we have a whole session on conscience and abortion, where we talk through how you can respectfully opt out of care so that you don't affect the patients in any way. And it's completely possible. Okay. Last question, true or false? The RCOG and BMA support the decriminalisation of abortion because they believe current UK law compromises clinical best practice. True or false?
Yeah, so the vast majority of people are saying true. Got one person who said false.
And it is actually true. So the RCOG, the BMA, the RCN, the FSRH, the Royal College of Midwives, the Royal College of General Practitioners all support the decriminalisation of abortion, as does the WHO as well internationally, for many reasons, but one of which it does compromise clinical good practice. It's stigmatizing, it prevents nurses from being involved. There are many reasons why abortion should be decriminalised. And as I said earlier, there have been 2 women this year already who've been prosecuted and imprisoned for having an illegal abortion. And there's another case going to court in a couple of months. And there are umpteen cases being investigated. So this is a really hot topic at the moment, because the majority of people think that nobody should go to prison for having an abortion. And whilst people can largely access legal abortion in this country, whilst it's still possible to go to prison, clearly we need to do something about that. And so we Doctors for Choice, which Corrina and I are members of, campaign quite actively to decriminalise abortion, as do all these other kind of main medical organisations. I have this style. There you go. And there are some of the reasons. Okay. So, in summary, abortion is still a criminal offence in mainland UK, where people who get pregnant and have abortions and people who provide abortions can go to prison for life. The 67 Abortion Act allows doctors to authorise and provide abortions. 2 of them have to agree the grounds of the act have been met. The law does not specify any specific circumstances other than those 5 grounds I showed you. And now we have telemedicine, because people can take the 2 abortion pills at home, which they couldn't do 3 or 4 years ago. And then, of course, the law allows all healthcare providers with a conscientious objection to opt out, as long as they don't impede access and give information to people. And abortion has been decriminalised in Northern Ireland. So are there any questions on this now, Charlie, or shall we wait until the end to take questions? And there are some resources.
There's no question in the chat. I actually do have a question, if you don't mind.
Sure.
In terms of the telemedicine, I'm assuming it was sort of, well, I don't know, but I'm assuming it was sort of COVID that pushed it to becoming, was the intention always to take that away after COVID was over?
Yeah, so NICE produced guidance in 2019 saying that we over-medicalised abortion care in this country. You know, everybody, until 2020, everyone who came for an abortion had a scan, everyone had blood tests, and if you're rhesus negative, everyone had anti-D. And so what COVID did is it gave us in the UK an opportunity to actually modernise abortion care, rewrite guidance, because not everybody needs a scan when they have an abortion. Not everybody needs blood tests. So it was actually, from our perspective and from patients' perspective, a huge improvement. So, but I think in terms of the Secretary of State for Health, who at that time was Matt Hancock, it was his intention that this was a temporary move. But of course, when they came to rescind the regulations, there was an outcry, and that's why it went to Parliament, where Parliament actually voted to keep the regulations in place. So they tried to rescind the regulations, but Parliament didn't allow them to. So yes, it was supposed to be temporary. But of course, as clinicians, once you improve your service, the last thing you want to do is go back and offer a service that is lower quality. So we were all delighted when these were made permanent.
And there were several very high quality research papers that were released looking at the improvements that telemedicine had made in terms of accessibility, in terms of acceptability, and that the safety was equal, if not higher, to pre-telemedicine. So that evidence was thankfully collected very rapidly and was already there when the government came in to try and rescind it. They presented a very clear case as to why that didn't make sense from a clinical perspective.
Thank you. We also have another question in the chat. Panna, sorry, I hope I pronounced that correctly, has said, in what cases would healthcare professionals be prosecuted?
Yeah, so there's only been one case actually since the Abortion Act was introduced when a healthcare professional has been prosecuted, and he was a bit of a rogue private clinician who was working in the private sector, and he went to do an abortion without really documenting anything or getting anyone to countersign. I don't think he even signed the form I showed you. So he's a complete rogue. So nobody has been prosecuted, but it is possible to be prosecuted if you provide an abortion in the UK without signing that certificate and having it countersigned by another colleague. So, of course, we don't do that, and we're very careful about countersigning it. But there was an incident in 2012 where some doctors across the country had been pre-signing the HSA1 form, the abortion form that I showed you, because they knew that any abortion done under 24 weeks, if it's what the pregnant person wanted, you could justify signing it. And so they would sign forms for their nursing colleagues so that the patients wouldn't have to wait for doctors to sign the form. But they were reported to the GMC after a CQC inspection across the country of abortion services in 2012. And so that practice was stopped. So you can see you have to get the paperwork right.
Great, thank you. There aren't any more questions in the chat.
Great.
Move on, thanks.
I'll hand over to Corrina, who's going to talk about types of abortion.
Okay.
Actually, there isn't one more question. Just come through from Letty. She said, with telemedicine, how is the issue of dating accurately assessed if no scans are done in terms of providing a medical surgical abortion?
Yep. I think you might be covering this, Corrina.
I think I am. Yeah. I think we will come to that. If we haven't come to this by the end of the second section, we will definitely talk about it.
Great. Thank you.
Okay. So coming on to types of abortion. So broadly, there are two types of abortion. So someone can have a medical abortion, which is where they take tablets and that causes them to pass the pregnancy, or they can have a surgical abortion, which is where the pregnancy is removed, either using what we call dilatation and evacuation or using suction vacuum aspiration. And you can see here we also subdivide each of these categories broadly by the duration of a pregnancy. So for medical abortions, as Jayne briefly mentioned, in Scotland under 12 weeks and in England and Wales under 10 weeks, you can have the tablets at home. If you are over 12 weeks, then in all circumstances, you would need to be taking your tablets in a clinical facility. So that would either be an NHS hospital or it could be an independent abortion clinic. In terms of surgical abortion, it's divided more broadly around 14 weeks. So if you are under 14 weeks into your pregnancy, the procedure can generally be done with either a manual or an electric suction device, which we will talk about in a minute. If you are over 14 weeks into your pregnancy, a little bit more preparation needs to be done, and then you can have what we call a dilatation and evacuation. I will talk through all of these in more detail in a minute. So, in terms of ending a pregnancy via medical abortion, these are the two tablets that we use. So we give mifepristone first, and the F is in red because it's the first tablet. And then misoprostol we give second, and the S is in red because it's the second tablet. So the mifepristone is given first, and that is an anti-progesterone. So you can see here, it does several things. So progesterone is crucial for the maintenance and development of an early pregnancy. So if you are blocking that progesterone, you are stopping that pregnancy from growing and from continuing. So that is via decidual necrosis, via detachment, and then it does a couple of other things which prepares the body for when the misoprostol comes. So it softens the cervix and it dilates the cervix slightly. It also importantly sensitizes your uterus to prostaglandins, which then means when 24 to 48 hours later you're given the misoprostol, it is more effective. And that is a prostaglandin analogue. And again, that works. It does soften and dilate the cervix, but also the main way in which it works is it contracts the uterus and it causes that pregnancy to be expelled. So if someone is having a medical abortion under 12 weeks, so under 12 weeks, that would be at home if they're in Scotland, at home up to 10 weeks if they're in England or Wales, or in a facility but under 12 weeks in England and Wales. They would take the mifepristone first. So that can either be taken at home or it can be taken in clinic. And then 24 to 48 hours later, as I mentioned, they would take 800 micrograms of misoprostol. So that's 4 misoprostol tablets. And they would either take them vaginally, so they can insert all 4 tablets into their vagina. They can take it buccally, so between the cheek and gums, or they can take it sublingually, which is where they put it under their tongue. And if they decide to put it orally, so either buccally or sublingually, it's really important to advise them not to eat or drink for 30 minutes and to let the tablets dissolve into the mucosa, because that's how they will work. We at Homerton and a lot of other abortion services will also give one extra dose of misoprostol, 400 micrograms, to maximise the chance that all of the pregnancy tissue passes in one go and they don't have any retained pregnancy tissue. Until surprisingly recently, so until 2019, both mifepristone and misoprostol were required to be taken in clinic. So you had to come in, take your mifepristone, go home, come back in, take your misoprostol, and then go home. Misoprostol, as I said, the law was changed in 2019, and the reason for that was there were countless stories of people who started to pass their pregnancy on the tube home, driving home, walking home, because for some people, the misoprostol can work within half an hour. And so they were having extremely traumatic experiences with heavy bleeding and clots before they'd managed to get into the comfort of their own home. So thankfully, that was changed several years ago, so the misoprostol could be taken at home. Now, since COVID and since telemedicine, the mifepristone can also be taken at home. So, as we've said, this is what you do. So you swallow the mifepristone tablet with water, then you have the misoprostol tablets 1 to 2 days later. We do always advise people to take some pain relief before they take their misoprostol, because, as I mentioned, for some people, within 20 to 30 minutes, they can start passing their pregnancy. They will always be provided with a stronger pain relief than what's available over the counter. So we provide them with codeine. Different abortion clinics might provide slightly different medication, but generally they will be provided with something. And then, as I mentioned, they take their 4 misoprostol tablets, they wait a couple of hours, and then they take, so for some people, they say if they've not bled, to take the extra 2 tablets. In our clinic, we advise them to take it even if they have started bleeding, to make sure they pass all of their pregnancy tissue. Once the bleeding has started, I think we talk about this in a minute. Mm-hmm. Yeah. But yeah, we will talk a bit more. So the bleeding is usually heavier than a period, and the cramping is stronger than period cramps. We'll talk about that more in a second. The other thing that we advise that's really important is to do a pregnancy test within 2 to 4 weeks, depending on what type of pregnancy test they're given. And that's to make sure that the treatment has worked. So again, we will go through this in a minute, but sometimes if there is pregnancy tissue left behind, or very occasionally the first set of tablets don't work as we expect, we need to, if they have a positive pregnancy test, they need to call us. They will always be given the number of their clinic, and then that's always available if they need any advice about anything. So misoprostol, the second set of tablets that they take, can cause some side effects. So we always make sure people are aware of these in advance. And this is about 1 in 10 people will get some of these side effects. So some people can feel really hot and flushed. On the flip side, some people can feel chills. They can feel really cold and shaky. A lot of people do feel a bit sick, and you are more likely to feel sick if you take your misoprostol orally. So you have fewer gastrointestinal effects if you take it vaginally. Some people will get a headache. Some people, again, will get some diarrhea, and some people feel a bit dizzy for a few hours. So these don't last. They're not long-term side effects, but it's really important that people are aware of them before they start taking their misoprostol. The other thing to mention in terms of if people take it orally is that they will get a chalky taste. So as the misoprostol dissolves, they get the taste of the tablet, which a lot of people find mildly unpleasant. So in terms of pain and bleeding for a medical abortion under 12 weeks, as I mentioned, you will have abdominal cramping that is more painful than your period. The very painful, intense cramping should last a relatively short period of time. We usually say sort of 4 to 6 hours, but on and off cramping, so settling to more like period level cramping, is normal for up to a week after you've taken the tablets. And as I mentioned, for pain relief, we will usually give codeine, also ibuprofen, paracetamol, and then we always advise people if they've got a hot water bottle or a heat pad, that can really help things. In terms of the vaginal bleeding, again, it will be heavier than the period and there will be clots, and the clots will be larger than someone would usually expect from a period. And that's particularly that, the further into their pregnancy they are, the bigger the clots are likely to be. Everyone's experience is slightly different, but that is sort of a general rule. And then that bleeding, again, the very heavy bleeding should resolve within about 4 to 6 hours, but bleeding ongoing is completely normal for 2 to 3 weeks. And for the first week, certainly it can be like a full period bleed. Most people will pass the pregnancy within 4 hours, and almost everyone will pass within 24 hours. So it is very rare for someone not to have passed their pregnancy 24 hours after they've taken their misoprostol. There are a couple of reasons why people might need to call us or why people might need to come back in. So the first thing that they need to think about is very heavy bleeding. So this is rare, about 1 in 1,000 people, and we'll go through the risks of abortion a little bit later. Will have very heavy bleeding. So we tend to advise people, if they've got the kind of super jumbo maxi pads, if they're completely soaking more than 2 pads an hour for 2 hours, that is probably heavier than we would want, and they should seek emergency medical care. So either call us so we can bring them straight in, or go straight into their local A&E. The next thing that people need to think about is if they've not had any significant bleeding 24 hours after their misoprostol. So as I mentioned, we would expect almost all medical abortions under 12 weeks to have passed the pregnancy within that 24 hours. So they may need more misoprostol. And the other thing that's really important is if they haven't had a scan, there is about a 1 in 1,000 risk that their pregnancy could be ectopic. And if they haven't had the bleeding 24 hours after the misoprostol, we need to bring them in to scan them to double check that their pregnancy is within the uterus. Because if it is an ectopic, then we need to give different treatment. The other things to think about, if they're having ongoing or new abdominal pain, if they're having fever, unusual smelling, discharge, or feeling generally unwell, again, they should get in contact with us. And the things we're thinking about there is there any tissue left behind? Is there any evidence of infection? So we would bring them in, assess them, and then give them any additional treatment if we needed. And then the next thing is as we said, at sort of 2 to 4 weeks, whenever they've been advised to do their pregnancy tests. If their pregnancy test is still positive, then they would definitely need to call us, and we would bring them in and reassess them and work out what's going on with that pregnancy. The final thing is, if they're still bleeding after 4 weeks, even if that bleeding is relatively light, we would expect the bleeding to have completely stopped by 4 weeks. So if they are continuing to bleed, we would want them to come in just so that we can assess them. So for medical abortions over 12 weeks, it's a similar process, but they are likely to need more misoprostol to pass the pregnancy because the pregnancy will be larger. So you can see you take mifepristone, you then have the first dose of misoprostol, and then 3 hourly, you will take misoprostol 400, so that's 2 tablets, until the abortion occurs. And as I mentioned, for every medical abortion over 12 weeks, it requires an inpatient stay. And so that's one, because they need lots of repeated doses of medication, so that can be better tracked when they're in with us. Also, again, because there's more pregnancy tissue to pass, it's likely to be more uncomfortable. So they might need additional pain relief, and we can provide that for them if they're in hospital or in a clinic. After 22 weeks, if someone is having a medical or a surgical abortion, the advice is to perform feticide, so to end that pregnancy before starting the process of the abortion to avoid the possibility of any signs of life or a live birth. And that can be done in 2 ways. You can either give digoxin or you can give potassium chloride. And each abortion clinic will have their own way of performing a feticide. Coming on to surgical abortion. So as I mentioned, there's two main types of surgical abortion. So up to 14 weeks, we do what we call vacuum aspiration. And so there we prepare the cervix with either misoprostol or mifepristone. So you can see when we use them for a medical abortion, part of the reason they're useful is because they soften and prepare the cervix. So we can also use that when we're going to do a surgical abortion. These can be done under local anaesthetic, so people can be awake with local numbing given into the cervix. It can be done under a general anaesthetic, so when they're completely put to sleep, or it can be done under conscious sedation, where someone is sort of not fully anaesthetised, not fully asleep, but they're also not fully aware of what's going on. So then once the patient is prepared, we will use, so on the left, that is what we call a manual vacuum aspirator. And then on the right, that is an electric vacuum aspirator. Both of those work by using suction to aspirate the pregnancy tissue. So we attach a cannula onto the end of those. The cannula goes through the vagina, through the cervix, into the uterus, and then we use suction to remove the pregnancy tissue. It is extremely quick, so you can see it takes 5 to 10 minutes. At earlier pregnancy duration, it may not even take 5 minutes, so it's very quick. And it's usually, the recommendation is that it should be done under ultrasound guidance, so you can see the pregnancy and you can see that you're removing the pregnancy. Coming on to when someone is over 14 weeks into their pregnancy, we use something called dilatation and evacuation. So again, their cervix needs to be prepped, and that can be, if they're under 17 weeks, you can use mifepristone as long as it's got plenty of time to work, you can use that. Generally, particularly once they're getting in sort of further into their pregnancy duration, you would use what we call osmotic dilators or Dilapan. So you can see the picture on the far right is what Dilapan look like. So they're little rods. We insert them directly into the cervix and they sit overnight usually. And what they do is they absorb the fluid that's naturally produced by the cervix and they gently expand. And that expansion softens the cervix and also gently opens it, which means that when you then come to remove them the next day when you're doing the procedure, the cervix is soft and the cervix is slightly open, so it makes the procedure easier and safer. It's generally done under a general anaesthetic in the UK unless there was a strong medical reason why a general anaesthetic might not be safe. So I've once been involved in a case where someone had a spinal anaesthetic because they had extremely brittle asthma and the feeling was a general anaesthetic would be more dangerous to them. But if there isn't a medical reason, general anaesthetic is generally used. And then, so you will remove the pregnancy tissue using forceps. So you can see on the left here, those are the forceps we would generally use. You insert them again through the vagina, through the cervix, into the uterus, under ultrasound guidance. You remove the pregnancy tissue, you remove the placenta, and then you can use vacuum aspiration at the very end of the procedure just to maximise the chance that all of the pregnancy tissue has been removed. These take slightly longer, but again, the majority will take between 15 and 20 minutes. So again, it's a very short procedure time. In terms of after a surgical abortion, so this is at any pregnancy duration, you get some abdominal cramping. It should be improved with simple pain relief. And actually, generally, people find the cramping settles very quickly. Within a sort of a day to a couple of days, we wouldn't expect them to have any significant cramping. In terms of vaginal bleeding, they will have some bleeding. That's completely normal. But usually, it's between about 1 to 2 weeks. Actually, lots of people, it might be sort of 5 to 7 days. And after 2 days, we wouldn't expect it to be heavier than their period. So their bleeding should lighten quite quickly. And their next period will usually come within about 4 to 6 weeks of the procedure. If they're having a general anaesthetic, they need to fast. And if they're having a general anaesthetic or conscious sedation, they do need an adult escort, so someone over the age of 18. So for some people, we see quite a lot of young people in our clinic. For some people, that might be more difficult. Previously, people would say, oh, you shouldn't get in the bath, you shouldn't swim, you shouldn't have sex or use tampons, but there is no good evidence on avoiding this. So there's no clear evidence that it causes any problems. Again, with a surgical abortion, there are some reasons why you might need to seek medical attention. So very heavy bleeding, that would be, again, soaking 2 pads. That is less common with a surgical abortion because generally people will be regularly assessed until they've been discharged. And if their bleeding was this heavy at the time, they wouldn't be discharged. But it can happen occasionally. If someone has a high fever or they're feeling very unwell, or if they're having symptoms of anemia, they should be coming in and we would want to assess them. At that point, we might want to repeat a blood test to look at their full blood count or check for any markers of infection. Any worsening abdominal pain, any unusual vaginal discharge, or any signs of an ongoing pregnancy. So if they're still, in a week's time, in 2 weeks' time, if they're still feeling very nauseous, if their breasts are still very tender, we would want them to come back to us. Thinking about the complications of abortion, so the important thing to highlight for both of these is that they are very safe. So you can see here, all of our complication rates are very low, but they vary slightly between a medical abortion and a vacuum aspiration. People very rarely make a decision based on this, but we do always inform people of it so that they're aware and can factor it in. So with a medical abortion, you are less likely to end the pregnancy and you are more likely to have some retained pregnancy tissue. So you can see here about 1 in 100 people who have a medical abortion under 12 weeks will have an ongoing pregnancy after they've taken the tablets. Whereas if you're having a vacuum aspiration, it's 1 in 1,000. So it's very, very uncommon. In terms of a small amount of retained tissue, again, you can see here about 2 to 5 in 100 will have it after a medical abortion, whereas only 1 in 100 will have it after a vacuum aspiration. The risk of infection is slightly higher if you have a surgical procedure. So you're inserting something from outside of the body through the vaginal canal into the body, and that slightly increases your risk, although it's still less than 1 in 100. Whereas for a medical abortion, it's 1 in 1,000. Hemorrhage, risk of very heavy bleeding, again, is very rare, so 1 in 1,000 for both. And then the extra thing is thinking about potential surgical complications when you're having a surgical abortion. So about 1 in 100 may get a cervical tear, and about 1 in 1,000 may get a uterine perforation. So that's making a small hole in the uterus, in the wall of the uterus itself. Couple of things to highlight. So these risks do increase to an extent in frequency and also in severity as the pregnancy duration advances. So the earlier, if someone is certain of their decision and you're not in any way worried about coercion, the earlier they can access an abortion, the safer it will be. It's also really important to highlight that abortion does not affect future fertility and it does not affect the risk of breast cancer. Those are myths that are sometimes spread by certain anti-choice groups, and it's really important to highlight that there's been a lot of research on that and there is no impact. After a medical abortion, because as you can see, 1 in 100 pregnancies won't end and 2 to 5 in 100, so up to 1 in 20 will have some ongoing tissue, it's very important to make sure they do their pregnancy tests 3 weeks after to double check everything's passed. So these are the key points. So for a medical abortion, you can usually proceed on the day of the appointment. And actually, when we run our clinics, lots of people say to us, they've already waited maybe a week or so to speak to us. They're certain of their decision. What they want is to be able to access an abortion as quickly as possible. So some people will opt for a medical abortion because you can usually proceed on the day of the appointment. Other people also find it helpful to be at home with friends, with family, with their partner. So they prefer to do that than to have a surgical abortion. Some people feel it's more natural and they'd rather go through that process. But it's important for them to be aware that there is more pain and more bleeding than a surgical abortion. So for some people, that's not suitable for them and they would much prefer to have a surgical procedure done with less pain and bleeding. With a surgical abortion, as I said, it's under 14 weeks. It takes 5 to 10 minutes. There's no cuts or scars. Some people like the fact that there are medical staff present throughout. So they like to feel supported by medical staff. Some people want to have a copper coil or a hormonal coil fitted at the time of the procedure, and that can be done if they're having a surgical abortion. And as I mentioned before, lots of people feel that actually having the method that has less bleeding and pain suits them better. So the next thing to think about is future contraception. So at a surgical abortion, all methods of contraception can be started at the time. So you can give them, as we said, copper coil, hormonal coil, you can give them an implant, injection, pills, rings, patches, whatever they'd like. With a medical abortion, most methods can be started. So pills, patches, the injection and an implant can be started or fitted at the time. There are a couple of things to consider. So coils, a copper coil or a hormonal coil, can only be fitted after we're certain that the pregnancy has passed. So that would be when they've done their pregnancy test in 3 weeks' time, and provided that their bleeding is tailing off as we expect it to, at that point we could then fit a coil. The other thing is the vaginal ring. So we wait for that to be started until the pregnancy has passed. The key thing to mention is if it started within 5 days of an abortion, all of the methods are effective immediately. So often if you start them at a later time, you might need to wait between 2 and 7 days for them to be fully effective. But if you start them immediately after the abortion, you don't need to have that waiting time, and they'll be protected from pregnancy straight away. So thinking about facilitating choice. So in terms of, we often get asked which method is best, which method people should access, and there's lots of things that people will consider. So with provider facilities and skills, unfortunately, that is a consideration that needs to happen. So if someone has a medical condition that means that they cannot have their abortion provided in an independent clinic and they need to have the additional support of an NHS clinic, there are only 5 hospitals in the UK, in England, in the UK, that can provide a surgical abortion up to 24 weeks. And 3 of those are in London. So if you live in Devon and you are 21 weeks pregnant and you need an abortion for whatever reason, and you have had 2 previous cesarean sections, or you have asthma that's not well controlled, or you have high blood pressure, lots of different reasons, if you want to have a surgical abortion, you would need to travel a significant distance, either most commonly to London, to access your care. So unfortunately, that's something that has to be considered in a small number of abortions. Pregnancy duration, as we've also mentioned, so if someone in England or Wales is over 10 weeks, they will not be able to have a medical abortion at home. So that will impact the type of abortion that they can access. And then there are other things that people will consider. So as we've mentioned, the timing. So lots of people want to have their abortion done as soon as possible. So for them, a medical abortion is likely to happen slightly faster than a surgical abortion, because generally we can't book people in for surgical abortions the same day. We do have lots of provision, so generally it can definitely be within a week, but you can't start at the same time. Some other people want to plan it with other commitments. So some people find having a surgical abortion under local anaesthetic, they only need to come into us for sort of 2 hours or so. Some people find that's much more convenient for them. Process, as we've mentioned, so thinking about pain and bleeding. Some people don't want to have a procedure done. Some people don't want to have a general anaesthetic. And some people don't want to see any of the pregnancy tissue. So that's things to consider. If other factors that people might think about, so if they want to have a coil fitted, that might impact it. And then individual circumstances, which are often amongst the most important in people's decision making. So someone wants to be at home, someone's previously had an abortion, and either they found the method suitable for them or they really found it unsuitable. Both of those can happen. Or we often, as as I said, we see young people, if they live with their parents, they're not planning to tell their parents. That can make a medical abortion at home difficult because you will be bleeding heavily and having quite significant cramping for several hours. So these are the aims of a pre-abortion consultation. So when someone comes to us in our abortion service, this is what we want to do. So we want to determine which methods they can safely have. And so we need to know when their last menstrual period was, get a medical history, and then a scan if required, as we've mentioned. We want to facilitate choice. So first choice is whether they want to end or continue the pregnancy. We do see people coming to our clinic who are unsure of that decision, and we can support them with that, and we can provide them with counselling if they need. If they are certain of their decision to end their pregnancy, then we want to facilitate choice in terms of what type of abortion and if they want any future contraception. Really important, and we will do this with everyone, is to screen for anyone who might need any further support. So any safeguarding concerns, any concerns regarding domestic violence, or anyone who you think is vulnerable, who hasn't spoken to anyone about their abortion, who you think might benefit from additional counselling. Then organising the abortion and the contraception if someone wants it. And then really importantly, to create a safe and respectful space. And we will come on to talk about that more later. If you guys want to know a bit more about, I'm just going to hide that. Yeah. If you guys want to know a bit more about the sort of medical aspects, as we've mentioned, so Jayne was involved in making abortion safe programs. So there's 8 modules. They're excellent, and they have lots of information on clinical aspects of abortion, and they're free open access e-learning. So you can see here, there's information about pre-abortion care, medical abortions, surgical abortions, managing complications, and post-abortion contraception. So if you search for ARCOG Make Abortion Safe, you should be able to find these resources, and we can provide the link if people want them. Any questions about types? Oh, scan. Yeah, we didn't go through scan. We often have that in our PowerPoint, so I think we thought it was going to be there. So in terms of assessing whether someone needs a scan, there are 2 main things that you need to assess for. So one, as was mentioned in the question, is to make sure that you can identify their pregnancy duration. So if someone has a regular menstrual period and they remember and they're certain of the first day of their last period, and they are not breastfeeding and they haven't been taking any hormonal contraception in the last 3 months, including thinking about morning after pills and things that might shift their menstruation, and that period was a normal period for them, so they bled as they would have expected, that period can be used to accurately date their pregnancy. So from that perspective, you then don't need to do a scan. The other thing that's important to assess is ectopic risk factors. So as I mentioned, in the general population, the risk of an ectopic that's been seen from previous abortion data is about 1 in 1,000. However, there are certain things that will make you higher risk of an ectopic. So if you have previously had an ectopic before, you will definitely need a scan because you will be at higher risk of a future ectopic. If you have a coil-in, then you are at higher risk of an ectopic, so you definitely would need that. If you've had previous surgery or known damage to your fallopian tubes, so if you're known to have had previous complicated PID, or as we said, any lower abdominal surgery that's impacted your tubes, you would need a scan because you're at higher risk. And the final thing to assess is symptoms of an ectopic. So if anyone is having any sharp, particularly one-sided lower abdominal pain, any funny spotting, funny bleeding since they found out they were pregnant, particularly within the last week, we would bring all of those people in to have a scan to make sure that their pregnancy was intrauterine. If they don't have any of those things, then we can be reassured that their ectopic risk is at a minimum, and we know when their pregnancy was. So we can provide them with whichever method of abortion they like. if they are having a surgical abortion, they will have a scan anyway. And that's because we need to be absolutely certain that the pregnancy is intrauterine before we go in and instrument their uterus. Otherwise, if someone were to have an ectopic pregnancy, so we do very occasionally see this, the medical abortion will not damage them. It won't harm them, but it won't end the pregnancy. So we sometimes see people who are very early in their pregnancies, who are maybe 5 weeks, 5.5 weeks, who haven't developed any symptoms from their ectopic. We will give them their tablets. Then they will 24 hours later call us and say, I haven't had any bleeding, I haven't had any cramping. We bring them in, we identify their ectopic, and then they are managed via the ectopic pathway in our hospital. Does that make sense?
Yes, I think so. It answered it for me, but if anyone's got any more questions, feel free to put it in the chat.
Yeah, otherwise I will hand back over to Jayne to talk about UK abortion provision.
I go for it.
Okay, great. Thank you, Corrina. So I'm going to talk about UK abortion provision now, and you need to go back to Menti for this. Corrina, would you like to speak the code in case anyone doesn't have it?
The code is 6887 5832. Maybe it's worth, Charlie, are you able to put that in the chat?
Yeah, I will do.
Perfect. So yeah, 6887 5832.
Thank you, Corrina. So I am going to give you an overview of UK abortion provision now by reading out a statement and then asking you to match the percentage to the statement to the nearest percent. So we've got 5 figures here and we'll see how you do. So first question, what percentage of pregnancies in the UK are unplanned? To the nearest percentage.
We'll give you another 30 seconds. Okay, so the majority of people have said 33%, and then we've got some votes for 50%, and then a couple of votes for 66%.
66 is great. So well done, those that got 50%. So it's actually 45% of pregnancies in the UK are unplanned. That's pretty standard actually across the globe. It's more or less around, or between 40 and 50%. So yeah, so 45% of all pregnancies are unintended. Okay, that doesn't mean that those people will have an abortion, but it's just they didn't mean to get pregnant at that time. So what percentage of pregnancies in the UK do you think end in abortion? So at any one time, the percentage of pregnancies. Yes, this is quite an easy question because it's got to be under 50%. Although, of course, some people who have unplanned pregnancies do end up having abortions, but that's quite a low number.
Okay, yeah, so we've got the majority of people have gone for 25%.
And that is absolutely correct. So at any time, a quarter of pregnancies will end in abortion. And so it's really worth thinking that a third of births in Britain are either unplanned or people are ambivalent about them. Okay, so that's quite a high percentage of people. So how many women experience abortion in mainland UK? And obviously some trans and non-binary people will also experience abortion. We just don't have the stats for that. So how many women experience abortion in mainland UK?
Okay, so we've got a split. Majority have gone for 25% or 33%. Then we've got a couple of votes for 50 and 66.
So it's actually 1 in 3 women will have an abortion by the time they reach 45 years. And when you say this to patients who have abortions, many of them actually are quite surprised at how common abortion is. So that's a very useful thing to be able to say to people. And you can see here the number of abortions going up since 2016, and they continue to rise. And we can talk about that if anyone has any ideas about why. Corrina and I have some ideas. We can't prove it, but if anyone's interested in that, we can talk about that at the end of this section. Okay. So medical abortions account for what percentage of total UK abortions, do you think? So how many people are having medical abortions compared to surgical abortions?
All right, so the majority of people have gone for 66%, a couple of people have gone for 50%, and one's gone for 90%.
Okay, so well done, that one person. So it's nearly 90% of abortions in the UK are now medical. And so you can see this has gone up. And in fact, during COVID, it's shot up, okay, from 66% in 2017 to 85% in 2020. And it continues to rise as medical abortion pills become more accessible. So the vast majority of abortions in the UK are done with pills. And you can see here, and this is from 2011, how until 2011, surgical abortions were more common, and how since 2013, medical abortions have undertaken surgical abortions. And you can see here, we really don't do that many surgical abortions anymore in comparison to medical abortions. So there are over 200,000 abortions performed in England and Wales every year, and the vast majority of those will be medical. So what percentage of abortions are funded by the NHS, do you think?
So the vast majority have gone for 90%, but we've got a little bit of voting for the others for 66, 50 and 33%.
So it's actually 99% of abortions now are funded by the NHS. That doesn't mean that they take place in the NHS. It just means that they are free to people who seek abortions. But 3/4 of them take place in what's called the independent sector, but under NHS contract. So organisations like British Pregnancy Advisory Service, BPAS, or MSI UK, or NUPAS provide the vast majority of abortions, and BPAS are the biggest abortion provider in the country. And so the NHS is only providing 23% of abortions. Okay, and this has changed enormously over the last 20 years, when you can see back in 1981, about half of people paid for their abortion, so that they were done privately and paid for by the person who had the abortion. And this has decreased, and the number of abortions that are funded by the NHS has increased until it's practically all of them. But the independent providers have done more and more abortions. This has had impact on certain aspects of training and other aspects, which again we can talk about if people are interested. But that's the sort of setting of abortions now in the UK. Largely independent sector, who do a really great job and are really efficient. And the NHS sees, Corrina mentioned this, those with more complex care will come into the NHS for their abortions. Okay, what percentage of abortions are carried out at less than 10 weeks of pregnancy?
Okay, so we've got a split here. So we've got the majority of people have said 50%. Then we've got quite a lot of people have gone for 66%, and then a couple of people have gone on either end, so 25% and 90%.
Well done, those that chose 90%. So it is 89%, so almost 90% of abortions are carried out under 10 weeks. That was in 2021. And that's been increasing. You can see 82% in 2019 and 77% in 2010. So we are getting better at providing abortions earlier during pregnancy. And of course, that's good for everyone. And making medical abortions more accessible is a part of this figure. So overall, the majority of abortions in the UK are done under 10 weeks with pills. And you can see here there's this graph which depicts that. So the majority of abortions are done early on in pregnancy, but there will always be a consistent number of people who present later on in pregnancy for their abortions. And this is the same globally, and it's the same in countries where abortion has been completely decriminalised or where abortions are criminalised. There is always a small percentage of people who need to access abortion later on in pregnancy. And there are very specific reasons for this. So I'm just going to ask you to consider now for a minute, why might people present for abortion later on in pregnancy? Okay, well, the majority present under 10 weeks, under 7 weeks actually. But why? What are the reasons? What groups of people might present at, say, 18 weeks, 20 weeks? And they're very, very specific groups of people. And I'm sorry we can't talk to you here and get your suggestions, but I'll just let you have a think about that and then go through them.
Post in the chat.
If I could see it, I would. Okay, so here they are. So the most common reason is fetal anomaly. Majority of those are not diagnosed until over 20 weeks. Of course, they're going to present later on in pregnancy. Then those that don't recognise they're pregnant, that could be because they just don't show, or they're taking, for example, the progesterone-only pill. They don't have periods, and they don't realise they're pregnant until they're later on in pregnancy. Those that have a significant change in circumstances. So they start off with a wanted pregnancy, but then they develop a medical condition which makes it dangerous to continue their pregnancy, or their partner leaves them. So what started off as a wanted pregnancy suddenly becomes untenable, or they lose their jobs, or they can't pay their mortgage. So that's a very specific group of people. Can be difficulties in accessing abortion as well, less so in the UK where abortion is more accessible, but still some people find it difficult to access abortion, perhaps because they live in rural areas, or for other reasons. They might be trapped in an abusive relationship, so they find it difficult to access abortion. They might be agoraphobic. They might not have the money to get to an abortion service. So there are reasons why people still find it difficult to access abortion. They might be pregnant and they just can't make their mind up. And Corrina and I recently have seen quite a number of people who they really don't know what the best thing for them is. And then time ticks on, and we try and support them as best we can. But of course, ultimately, they need to make a decision. And the default is to continue the pregnancy if they don't do anything. But that doesn't feel right to them. But then having an abortion doesn't feel right. And so, again, if people in this really tricky situation, they can actually get to 20 weeks or so before they make a decision. And then people who are marginalised or vulnerable or in really complex and challenging social situations, again, people in domestic or abusive relationships, people who are being coerced into continuing their pregnancy, but they really don't want to. People who have severe mental health conditions or learning disability or addicted to drugs and alcohol. So those people. So we do see quite a lot of vulnerable and marginalised people in our service because we operate at 24 weeks. And again, these reasons they're global. Okay, so every abortion provider will see people in these groups of people who need to access abortion later on in pregnancy. And so when you run an abortion service, you always need to make sure that people can access abortions right up until the legal limit. Okay, otherwise you do not serve these people, some of whom are extremely vulnerable. Okay, a couple more questions before I hand back to Corrina. What percentage of individuals having an abortion have had more than one abortion, so have had previous abortions? We've got a split here.
Yeah, we do. Okay, so we've got a split between most of the options. So the most popular one is 50%, but then we have a split between 66, 33, 25.
Okay, brilliant. And actually it's 43. So we say 50% is near us, but we'll take 33 as well. So many people have more than one abortion. Again, this can be, when you see people who've had more than one abortion, it's so important as healthcare providers to be really careful about your language and not stigmatise people, which Corrina will talk about in the next section. But it's really useful to say to them, look, so many people have more than one abortion. Okay. And then lastly, what percentage of individuals having an abortion already have children?
Okay, so the majority of people have gone for 50%, some have gone for 33 and some 25.
So it's actually more than that. It's 57% of individuals having an abortion already have existing children. And I wonder if that will go up this year, actually, with the cost of living predicament that we're in. And people, they can't afford to feed their current children, let alone having another child. And so you can see here, I said, what's the significance of these statistics for you? What sort of picture does it paint? Well, you can see that abortion is extremely common. Most people access abortion under 10 weeks. Most people have in the UK have medical abortions. Many people, if I haven't put that graph in, but more and more people are actually older than the 20s now. So there are more older people, so people over 35 having abortion, and less younger people, which is not generally what people understand when they think about who has abortions. Basically, everyone from every walk of life has abortions. And very importantly, there will always be a small number of people who need abortions later in pregnancy. Okay, any questions before we move on to the last section?
No questions, no.
Brilliant. We'll move straight on to Corrina and then we'll shut the slides down and take questions at the end.
Okay, so the last section, as we've mentioned, is thinking about counteracting abortion stigma. So have a little think, have a minute to think about, so what do people who have unplanned pregnancies need from their healthcare provider?
If anybody wants to pop anything in the chat and I can call it out.
Yeah, that's apt. Yeah, exactly. If anyone wants to, please do. Otherwise, just have a think to yourself and then we'll go through it in a second.
And what we mean by that question is we know they need clinical care, but what on top of clinical care?
Yes, exactly.
How do they need their abortion provider to act and do?
Okay, so coming on to this. So these are some of the things that we think are really important. So to not feel judged. So definitely lots of the people that we see in our abortion clinic, you can feel that they feel primed to feel judged by the people around them. And so giving them that little bit of extra support, making sure they understand that you're not judging them is really important. Some warmth, support, which, is important for all clinical care, but can be particularly important when someone feels they're in a sensitive situation, like with an unplanned pregnancy. Some people feel really guilty about their decision to access abortion care, and they might need a bit of extra support in terms of being told that, this is a very common decision. They're not a bad person for making this decision if it's the right decision for them. To not be repeatedly asked if they're certain about their decision. So we know that this can happen, and we know that often healthcare professionals aren't doing it from a place of judgment. They're just doing it so that they can tick the box to say that this person isn't being coerced. But we know that that can definitely make people feel judged. And someone you knew a 17-year-old went into a clinic to access an abortion and was asked so many times if they were certain that actually they left without accessing that abortion, even though that was what they wanted, because they felt so judged, like this person didn't think them having an abortion was the right decision for them. So it's really important, if you've asked and they've said they're certain, that is your response. And again, so to be told they're not alone, that it's very common, that it's just another part of reproductive health care. So lots of people won't need that actively spelt out to them, but we do get people who come in feeling judged, feeling upset, and that can really support them. So these are some other things to think about. So respectful care actively counteracts stigma. So we've said a lot of these already. Encouraging people to talk to someone they trust is really important. Starting with welcoming words. So, as we said, as you should use for all clinical scenarios, but it's particularly important here. If someone is coming in and they're going to sort of make a judgment of how their healthcare professional is going to be with them, if you smile, make eye contact, you start with welcoming words and you explain what you're going to do, that can really help settle them into the consultation. Actively listening, encouraging their questions if they have any, and making sure you give them clear and accurate information. Contraception is something that needs to be brought up sensitively at the time of an abortion consultation, and we will go through that briefly, how to bring that up, but you certainly don't want people to feel judged if they haven't been taking contraception or if they don't want any contraception moving forward. And then the next thing is to avoid assumptions and value-laden language. So we will move on to talk about that now. So this actually happened when I was an F2, maybe an F3, a couple of years ago now. You can see a patient had come in to the A&E I was working at, and they were pregnant, and it had very clearly said that they had a coil in. And I went in to see them. They were really upset. They were there with their partner and they were asking, does this mean I have to continue the pregnancy? I don't feel ready to have a pregnancy. That's why I had a coil in. And we talked it through, and I explained to them very clearly that they had options. If they didn't want to continue the pregnancy, they could access abortion care. And that sort of settled them in. We had a good conversation about it, and they felt quite calmed by it. Before they could go home, I needed to get a senior to come in and do a quick ultrasound scan to check there was no free fluid, no risk of a rupturing ectopic before they went home, and came back to see gynecology the next day. I went and got my colleague and I explained the full scenario to them. So they were well aware that this person had a coil in and that this wasn't a planned pregnancy. And before doing the ultrasound scan, the clinician came in and said, "Hello, mummy, we're not going to be looking at baby in any detail. When the specialist team, they'll scan baby in detail and explain it all to you, mummy and daddy." And it was terrible. And I could just feel how uncomfortable this patient and her partner felt. And I don't think this person did it with any judgment in mind. It was just how she'd got used to using her language around pregnant people. But it makes several assumptions there. You assume someone's gender identity, and you are very much putting value on this pregnancy. And so after my senior colleague left, this person burst into tears and was really upset. And we spent another 20 minutes talking about it, me reassuring her again that she didn't have to be a mummy if she didn't want to be. This wasn't a baby, this was a pregnancy. which she was very early in her pregnancy, and, you know, reiterating that she had options. But that really highlighted to me the importance of using language that is non-judgmental and doesn't place a value on things. So these are the sorts of languages to avoid. And actually, this is good in all early pregnancy. So if someone is using this language and they, you know, you can reflect it back to them, absolutely. But lots of people in early pregnancy, again, they might be ambivalent about their pregnancies. They might not feel ready to use these, or they might not identify as female or male. So again, using this language, it's good to avoid in early pregnancy and in abortion care. So instead of mother, pregnant person, or if you know their gender identity, pregnant woman. Instead of baby, pregnancy or fetus. And instead of father, the person you got pregnant with. And then thinking of a couple of other things. So repeat abortions, as Jayne mentioned, if you see someone who's had more than one abortion, using the term repeat abortions can make them feel stigmatized. So just saying what it is, more than one abortion, 3 abortions, 5 abortions, however many it was. Early/late abortions, again, that can put some stigma on people who are accessing abortion at a later point in their pregnancy. So late abortions can sound stigmatizing. So saying how many weeks, so an abortion at 10 weeks, an abortion at 20 weeks. We would definitely never use the term social versus medical terminations. It's just an abortion. And it doesn't matter why they're accessing their abortion, it's an abortion. Another thing really important that should be used in all sexual health, but again applies to abortion care, is avoiding assumptions about people's sexual relationships. So we always ask people, are you in a sexual relationship at the moment? Is this the person you got pregnant with? Do they know about the pregnancy? And then how do they feel? Are they supportive? And that avoids assumptions about sexual relationships, about people's sexuality. You just get the information that you need for a consultation without assuming anything. So as we've said, coming back to our aims of a pre-abortion consultation, creating a safe and respectful space is so important that we have it as one of our 5 main aims. So you can see it's really, really important, and it does make a huge difference to people's experience of accessing abortion care. And we see that regularly. I regularly have people who thank me for providing them with non-judgmental care and being so nice and supportive to them. And it's not rocket science. I don't do anything majorly different. I just make them feel comfortable that whatever their decision is about their pregnancy is up to them. So coming back to thinking about contraception, this is, as we mentioned, so there's a couple of things that we certainly do in our clinic and we'd recommend people to do when raising contraception. So the first thing is to leave it until the end of the consultation. So that person is aware you will be providing them with their abortion, and they don't have to, often people come in feeling like they might have to justify why they need it or fight for their abortion. Once they know that's happening, that can often settle the consultation, and you want to start with a very, very open question. So something like, would you like to talk about contraception? Did you want any contraception from us after we've provided you with your abortion? A very open question that allows them to answer. And then similarly to the, are you certain about your decision? Not to keep pushing it. So if someone says to me, no, I'm fine, I don't want to talk about it, I will not ask them anything more than that, because it is their decision. If they don't feel ready or they don't want to, some people won't need contraception moving forward. It's entirely up to them. If people do want to talk about contraception, then again, doing it in a very open and sensitive way, and particularly not overly pushing certain methods of contraception. So long-acting reversible contraceptives, they are the most effective methods of contraception, but if someone doesn't want one, that's absolutely fine. And they should be well aware that these are options, but they are options that they do not have to feel any pressure to take. So thinking about this, so you may well do a general practice job, very, very common to do, even if you don't do general practice in the long term, to do a general practice job in F2. So imagine that you're going in, Lara has come in to see you as her GP. She doesn't want to be pregnant and she says she wants an abortion. What sorts of things? Just have a think to yourself. Again, if you want to post in the chat, that's fine. But otherwise, I'll give you a minute or two to have a think about the most important things that someone in primary care should do for someone. So she's not in an abortion service, but she's come to her primary care doctor wanting an abortion. So yeah, have a think about what a GP should be conveying. So these are what we think in terms of general practice. So the most important thing is to tell her where she can get an abortion from. So signpost to a local abortion care service. So you can Google it. You know, if you know in advance, that's brilliant. But if you don't, you can Google it in the consultation with her. You can show her the number. You can show her how to refer. You don't need GP referrals in general to access abortion care anymore. So you don't even need to do a referral as a GP. You just need to provide Lara with the information so that she can call. You can sometimes also refer yourself online. So see what's local to where you're working, and then respond to her questions. So she might have some general questions about what to expect, and it's really good to have a basic knowledge of abortion care so that you can answer those general questions. Obviously, you're not going to be needing to give her all of the information about abortion care because that will be provided by the abortion clinic, but sort of general information is important. You can also achieve other aims. So you can ask when the last period was so that you have a rough idea of how pregnant she is, and that might guide what she's likely to be able to access. You can check for coercion. Often in GP, you know people, so you've met them several times. If there's previously been any concerns about coercion, previously been any concerns about a violent relationship or anything like that, you can explore that more and check, ask her about her decision if you feel that that's appropriate. And then really importantly, as we said, create a safe and respectful space. So the GP is, if someone's gone into their GP, that's the first port of call where someone may feel judged or may feel respected. And we've had a couple of people recently who have had really, really negative experiences with their GPs. So they've had GPs who've said, everyone I've ever seen who has an abortion has regretted it. And I had a 21-year-old who was told, if you could never have children ever again in your life, would you feel okay with the decision to have an abortion? Which is completely inappropriate, really upset her. And obviously she was certain of her decision. She still accessed the abortion because it's what she needed. She just felt more judged for it. So, primary care have an important role to play in making sure that people are supported. So thinking about how we generally can counteract abortion-related stigma. So Jayne's mentioned several of the things that we do to try and counteract this stigma. So Abortion Talk is a fabulous charity. So they work to support to destigmatise abortion. So they have a phone line that people can call, and anyone can call. So it can be someone who's had an abortion, someone who's thinking about an abortion, someone who works in abortion, the partner of someone who has had an abortion, anyone. They can call. They've been trained to speak to people and sort of support these conversations around abortion and trying to destigmatise abortion. As we've mentioned, we run Education for Choice, so that runs within medical schools. So we train medical students to go into secondary schools. It's now compulsory part of the secondary school relationships and sex education curriculum to teach about pregnancy options, including abortion. So we provide free sessions on abortion and contraception. If anyone is interested in Education for Choice and setting it up in their medical school, please contact me or Jayne. And then Doctors for Choice. So as Jayne mentioned, Doctors for Choice does lots to try and decriminalise and destigmatise abortion. So if you're interested, have a look. You can join. We run lots of events and things. So in summary, abortion is common, it's essential healthcare. It is still, unfortunately, very stigmatised in this country, and everyone can help by having conversations about abortion to destigmatise it. And that is everything. So we will stop sharing our screen, and if anyone has any questions, please, we've got 20 minutes. If anyone has any questions about anything, please post them in the chat.
Or you can just go out and enjoy this beautiful Saturday afternoon.
I was going to ask, actually, I think early sort of mentioned that you've seen a different sort of trend recently in the last years, and you said you weren't sure, but you had a couple of ideas about why that might be happening.
Yeah.
Could you share those ideas?
Sure. So two main things, I think. So, this is not said with a pinch of salt, actually, but the Tory government, have a lot to answer for here. So firstly, they changed the way in which contraception was commissioned. It's really boring, but it has had impact. So at policy level, they changed the way contraception was commissioned when they came into power in 2012. And what that's meant is contraceptive services throughout the country have generally decreased certainly in the number of people that they can see. Lots of community clinics have closed throughout the country, so it's been more difficult to access contraception, especially long-acting reversible contraceptive methods. So trying to get a coil fitted now, it can be quite onerous for people, and we see lots of people who are pregnant waiting to have a coil fitted. And then, of course, the cost of living. So people cannot afford to, and you see this, and when you're as old as I am, you see the trends. So after the Labour government got in 1997, after about a few years, you could see that the number of people, this is obviously anecdotal, but the number of people asking for an abortion because they can't afford it goes down. And then you get another Tory government in, cost of living goes up, services, the financing of public services goes down, and people can't afford to continue their pregnancy. Of course, you can't prove that, but abortion numbers have risen quite starkly this year, and most abortion providers are finding it difficult to meet the demand, and that will be the cost of living.
It's really interesting that the common themes that come up is about stigmatization and then also sort of access. I mean, I'm sure there's some people that even don't feel like they can go to ask for a morning after pill because of the million questions that you get asked if you go to a pharmacist. And I know some people would choose to buy it online because then they don't have to ask the questions, but obviously it's not an option for everyone.
Accessibility and stigma go hand in hand, absolutely. And that's why we do education for choice, because it's really important to go and give young people accurate and practical information about contraception and abortions. Not only does it help them to know what to do, but it also destigmatizes them as well. I mean, if it was up to us, we'd have a vending machine, where anyone could just whatever they needed around their reproductive health. But hey.
If anyone has any more questions, you can put them in the chat. If not, thank you so much for attending and participating. You'll be sent out the certificates for attendance after this event. Someone has said, if we do want to get in touch and work with Education for Choice, would you mind sharing your email again so we can get in touch?
Corrina will put both our emails in the chat.
Yeah, and if anyone wants to get involved in Education for Choice or has any questions about anything, please email either or both of us.
Or if you want the slides, we're very happy always to share our slides.
Yeah. Are you happy for us to pop the recording on our website for people to watch?
Yeah. Are you, sorry?
Yeah, that's fine.
Great.
And you can put the slides up as well if you want. So we make all our slides accessible to anyone globally, so that they can use the slides to teach in their own medical nursing midwifery schools, so they don't have to reinvent the wheel.
Yeah, and on the Doctors for Choice website, there are lots and lots of slides available. So if anyone does want to access them.
Absolutely. And we know that there's an issue in medical schools throughout the country with a lack of abortion teaching. We know that most medical schools get taught on the legal and ethical aspects of abortion, but they don't have access to abortion care placements, and they don't get taught on the clinical aspects of abortion or respectful care. And so we have been working with Doctors for Choice, but also with the RCOG and Faculty of Sexual and Reproductive Healthcare to try and improve abortion education at medical schools. So those of you that are later on in medical school, that's not going to help you. But if you're in the early years, hopefully by the time you finish, we will have helped to improve education. So what we've given you now are the basics, but at UCL people get 8 hours worth of teaching on abortion, which gives them the space to talk, to think, to really get to grips with this topic, so that when they're clinicians, that they don't stigmatise patients, and they have really sufficient information to provide good care.
Yeah, and it's, we had a first event in this series was a couple of months ago, and we invited people to come and talk about their own experiences with what they'd had teaching wise at their universities, and it was just all so different. Yeah. It was there's no national curriculum or any guidance on what should be taught to us, and I do think there's a common theme of it comes up in sort of an ethical debate.
Yeah.
Even though what we said is that abortion is really common. Yeah. And it's still stigmatized, even though it's so common.
And the thing is, having a debate about it just further stigmatizes it.
Yeah, and there will be people in that room who have accessed an abortion before, and to frame it entirely in terms of ethical debate, obviously you need to know about the law, that is important, but to frame it from a kind of moral perspective, as Jayne says, is massively stigmatizing, particularly for people who have already accessed abortion care within that room, and loads of people who will access abortion at some point in their lifetime in that room. They will remember that debate, and that will stigmatise them, compared to actually if the majority of your teaching is focused on a practical, understanding the legal aspects, but abortion. So as Jayne said, over 200,000 abortions happen in the UK every year, and appendectomies there's 30,000, and that's viewed as one of the probably the most common surgical procedure, certainly abdominal surgery. And you think about how much more common abortion is than that. The fact that it's not being framed from a clinical perspective and understanding the clinical aspects of it seems unacceptable.
And we know students want this teaching because we've done some research, and students of course, are clever, sensitive people who say, well, we know it's a sensitive topic, it's stigmatized, it's so common. Of course, we want to learn how to talk to people about abortion. We don't want to stigmatize them. We want to be competent when we speak to people. So it's not coming from students.
Yeah, because often educators will highlight the fact it's a sensitive topic as a reason not to teach it. But we can see here, and it's the same with things like end-of-life care, things like euthanasia, having education on topics that are sensitive is what medical students want. They want the understanding around these sensitive topics rather than for them to be ignored because they're sensitive and continue to be incredibly sensitive, as they move on with their medical careers. And it is, when I was a junior doctor, even before I went into community sexual and reproductive health, I saw countless people who had either recently accessed an abortion or were thinking about accessing abortion in A&E, in GP. So it is something, something extremely rare that people won't come across. It is extremely common, and just knowing the basics of how to have these conversations. As I said, we've seen firsthand in clinic the impact that it can have if someone in primary care is actively stigmatizing to someone who wants to access an abortion. They won't stop them accessing the abortion. They will just make them feel bad about it. And then you have to undo that. There's only so much you can do with your non-judgmental care to undo what's already happened. And, and this 21-year-old came into me being like, am I not going to be able to have a child in future because I've had an abortion at 21? Which is obviously not true. But that's what had been running through her mind until she'd had her appointment with us, was that, she might be making a decision to never have children again, which is obviously not true.
I think in terms of the feedback forms, I will send them out after the it's ended.
Thank you.
I don't think any more questions. Lots of compliments to your chat, but no more questions.
Both of us are really happy to engage with people. If they want to know more about abortion, then we're very happy for them to email us.
Absolutely, about anything.